Thank you.
Thank you very much, sir. And thank you, Dr. K.K. Rabal, sir, for giving me this opportunity. And also would like to thank Dr. Shelly Singh to come on the dais. And this session is going to be very brief discussion on when a patient really needs IVF. And then from a gynecologist's point of view, certain points would be discussed which come into our day-to-day clinical practice. IVF, most of us know, is in vitro fertilization, where we are bypassing the tubes and fertilizing the egg and sperm in the laboratory and transferring the embryos into the uterus. It started off in 1978, and not very soon after in Kolkata, the first IVF Indian baby was born. And India has done very well in this field, both in terms of the latest technology and also attracting foreign crowd in terms of it being quite economical as well as giving good pregnancy rates. However, when a patient is coming to an infertility specialist for IVF, there are certain basic pre-requirements that need to be fulfilled before we subject the patient to this procedure. Firstly, the indications should be crisp and clear. The patient should not have any underlying disorder that can hamper the pregnancy rate, and the patient should be very clear what to expect in the process, the cost implications, the success rate, so that the doctor and the patient are working hand in hand. If this one slide is clear to the audience, I think my work is done. These are the 4 major indications of IVF, and perhaps only IVF is the way to give these ailing patients a baby for whom they have been trying for months and sometimes years. That is bilateral tubal damage. If both the tubes are blocked, as is apparent on HSG and further confirmed with laparoscopy, and there is pelvic infection, it is very difficult to rectify the tubes and give a chance of natural pregnancy. Only the incidence of ectopic pregnancy in most instances increases, and patients with pelvic infection, mostly tuberculosis, and bilateral tubal block, mainly cornual block, are prime candidates for IVF. The next major indication is low sperm count. If a patient has azoospermia and sperm count that is less than 5 million, then chances of success with IUI, which is intrauterine insemination, is extremely low. Again, these couples have to be referred for IVF treatment sooner rather than later. Ovarian failure. Many couples coming to us are around 35 to 38 years of age, having tried treatment for more than 10 years, and when we assess their ovarian function, it is extremely low. Now, these candidates are very good patients for donor egg treatment. Again, IVF should be offered rather than medical, laparoscopy, IUI, etc., and wasting time and money. The final is irreversible endometrial damage. That is, the endometrium is less than 5 millimeters even in a med cycle. These couples, when we subject them even to IVF, the chance of success is extremely low, and surrogacy is the treatment option. There are other couples who would benefit from IVF, and these are couples who have received unsuccessful treatment for more than 3 years, either in the form of surgery, medicine, or gonadotrophins or IUIs. The slide that is showing an inclination at the top is the increased incidence of sterility as the lady's age is increasing. So age and only age is the primary indication for how quickly a patient should be referred and what are the chances of success for this couple. Finally, we have endometriosis, polycystic and mild to moderate male factor, who after a reasonable period of unsuccessful treatment should be referred for IVF. Then comes the patient to us, and we need to evaluate and assess, as I have already explained. We need to explain to them what the treatment cycle involves, how intensive it is, how many injections, how many visits, daycare, admission, etc. And consenting. We are using their own eggs, own sperm, whether donor eggs, donor sperm, surrogacy, all the consents should be in place. In evaluation before IVF, the ovarian reserve, the male factor, whether there is presence of endometriosis, whether there is a polyp in the uterine cavity, and how smoothly the transfer can go in is the work of the infertility expert to ensure that the patient is adequately prepared for the process. This is the treatment cycle in brief. I know it looks a bit busy. However, it basically starts from day 1 of the menstrual cycle, and about day 13, 14 is when we do the egg collection, and followed by the embryo transfer. So usually the protocol that we follow is the antagonist protocol, and the IVF cycle is completed in about 2 weeks' time. It involves extracting the eggs by general anesthesia using transvaginal guide and needle, fertilizing the egg and the sperm in the lab. This is simple IVF. And this is ICSI, which is intracytoplasmic sperm injection for very low sperm count, which is done under the microscope, and further putting the embryos in the dish and in the laboratory for culture. This is how a fertilized egg looks like with 2 pronuclei, and this is how it looks on the next day with 4 very good sized cells inside. And then we do the process of transfer, where the embryos are loaded in the catheter and guarded by 2 air bubbles so that it is visible under the microscope and we know exactly where we are going to put the embryos. Now we need to explain to the patient that when the process has been done, this is a slide from Guy's Hospital, London, where I trained, and this is more than about 5 years ago. Then the take-home pregnancy rates were about 25%. Now we have increased our pregnancy rates, and take-home baby rate is between 30 to 45%. However, this needs to be very clear that not all couples who are going to start with the treatment are going to end up having the baby in the first attempt. However, the pregnancy rate in 3 successive cycles are about 70 to 80%. There are a lot of myths associated with IVF. Some people think it's unnatural. However, if the tubes are blocked, there is no more natural method than taking the egg, their own egg and their own sperm, and having their own baby. Some people are concerned whether it's going to be their own egg or their own sperm. Again, that assurance is given to the couple that there will be no gamete manipulation. People think it's hugely exorbitant. I agree it is expensive. However, in a metropolis like New Delhi, where maybe a cholecystectomy will cost up to 1 lakh, a cesarean may cost up to 1 lakh, an IVF cycle is between 1.2 to 1.3 lakhs per attempt. Exorbitant, I agree, but not hugely. So many patients can afford it. Some people think it's end of the road, that if an IVF cycle is not successful, they will never get pregnant. That again is not true. We have many couples after successful or unsuccessful IVF cycles have become pregnant on their own or through other methods. I would now like to have a very small interaction with our gynecologist practicing in South Delhi, Dr. Shelly Singh, and these would be briefly few questions that a gynecologist experiences while dealing with an infertile couple. Thank you.
Thank you, Dr. Kaveri. I think that was a very short and sweet but very elaborate kind of overview about infertility as well as IVF. Now, there are some questions which we do have as practicing gynecologists. The first question would be, when do we actually start off with investigations of a couple for infertility? Because we often come across girls who've been married for 4 months, 5 months and highly pressured to have a baby. When should we actually begin to investigate for infertility?
That's a very good question. There are very clear guidelines on it. If the lady is less than 35 years of age and has been trying for more than 1 year, then definitely investigations need to be started. However, if the lady is more than 35 years, more than 6 months of trying, then investigation should be started straight away. If there are known problems like there is sexual dysfunction, there is low sperm count, there is tubal block, then treatment should start straight away immediately.
Now, what is the association of sexual dysfunction and infertility?
Sexual dysfunction, about 30% of the couples come with us this problem either in the form of erectile dysfunction or vaginismus. Now, it could either be the cause of infertility or infertility can lead to sexual dysfunction. We need to identify the cause in form of hyperprolactinemia, hypothyroidism, diabetes, and then we need to treat them. Many a times a simple process, and I have had innumerable couples getting pregnant with this process, which is called artificial insemination. It is a process which is taught to them in the OPD and they practice it in their homes, and majority get pregnant within 6 months of time. So I would recommend that any couple coming to a doctor with sexual dysfunction should not just be sent away by saying, now you go and try and it will happen. Sometimes it does not happen and they need some aid. And this very simple aid of artificial insemination is available.
The next question which most people pose to us is that, please tell us about the fertile period. When do you think ovulation occurs? And sometimes even the other practicing clinicians are a little in a dilemma as to when ovulation happens. How can we predict ovulation?
Infertile couples are very at stress trying to find out when exactly to have intercourse to get pregnant. We need to kind of emphasize to them that if they try to pinpoint one particular date, then the stress levels will go. There might be performance anxiety. Firstly, in a 30-day cycle between day 10 to day 22, if they have alternate intercourse, that is the best way to get pregnant. However, if they want to be more accurate, then we have ultrasonic methods to detect ovulation and LH kits that are now available in the market to determine the date more accurately.
Now, there are a lot of patients who come to us who get married late and who are planning conception at a much later age. There would be people at around 35 years and above who come to us and who ask us, what do you think my chances are of getting pregnant? Now, how can we actually determine the ovarian reserve?
This is a very common problem that we are facing nowadays, especially at the Max IVF Center where I sit. I get many high professional ladies coming to me around 35 years, married, not married. They say, you just let me know how long I can wait. I don't have the time to get pregnant now. But it is as a duty of a gynecologist as well as the infertility expert to explain to them that the ovarian reserve diminishes after 30 and more so after 35, whatever be your test results. So they should not delay pregnancy further. However, there are certain methods, age, FSH estradiol, the antral follicle count by ultrasound, and now more or less the AMH, the anti-Mullerian hormone. Between 1 to 4, it predicts a good ovarian reserve.
Dr. Agarwal now is pointing to us that there is no time left, so I think we'll just put an end to it. Can we just take one more question, sir? There is just something that I want to know about surrogacy as well as donation, because they are pressing topics of the day.
I think many couples coming to us need either donor egg treatment or surrogacy, and these facilities are available. The donors are usually either from the family or they are professional donors or they come through egg sharing. The cost of an egg donor cycle is about 1.5 lakhs. Now for surrogacy, these are professional surrogates coming to us, or they can bring anybody from their family or friend as a surrogate. If it is a professional surrogacy, it is expensive. It can go up to 9 to 10 lakhs till the baby is born. But however, if they get a surrogate from their family, the cost is much less. And like I mentioned earlier, for diminished ovarian reserve and endometrial problems, these are the only answers. I think we'll conclude now. Thank you very much, Dr. Shelley, and thank you, sir, for giving this opportunity.
Thank you.